Fires challenges.
I'll begin, Jonathan. I was asked to talk about key challenges that I see as necessary in making shared decision-making a reality in Massachusetts. And I, with the time available, came up with 3. And I think about these challenges sort of on 2 levels, that there are principle issues, issues of principle that we have to address, and there are practical issues that we need to address in each. The first is we need to change our mindset. And under principle here, I think there are 2 things we need to really see differently. The first is that we need to get to the place where we believe that people have the right and responsibility to make decisions that affect them, rather than what happens now, which is people are engaged in making decisions if we have an alliance, or we have trust, or we've known the person for 10 years. It isn't predicated, in my thinking, on a relationship. It shouldn't be. It should be right off the bat. The second way I think we need to change in terms of principles in our mindset is that we have a very acute care focused system. I think the medical model draws us toward that, and I think we've made a lot of improvements and a lot of headway on moving away from an acute care system. But the extent to which we don't really employ a mindset of, I'm going to use words that I don't even like, 2 of them, but chronic disease management, where you really have to engage the person in managing their health, is what is necessary in terms of changing our mindset. We work as providers with people over their lifespan, and it is not sufficient to talk to them in terms of acute. It's really engaging them in the long term about how to improve their lives, how to help them get the life they want. I think that I see it as a necessity because I've been on both sides of this. I have been frustrated when people have not been engaged in the process. And the natural result is that people do not move forward in their rehabilitation. And I've also been around long enough to see the incredible energy and dedication that results when people really want to do what the plan says they're supposed to do. So whether we believe in it or not, I am persuaded that it's definitely the most effective way to go. In terms of practicalities, both helpers and clients do not, in many cases, know how to have these types of conversations. They lack the tools and processes that we really need in order to make them happen. It is often very difficult to do this in the context of medical necessity, requirements for service payment. And fundamentally, we really need to ask ourselves, are we willing to hear it? Because if we listen to what people say they really want, it's going to be darn inconvenient. We're going to have to change a lot of things. The second thing I'd like to talk about is evaluating clients' capacity to make their decisions in a more just and clear way. The principle here is that there's a spectrum of decision-making ability within any person at any given time in their life, and between different people. People have trouble making decisions for many, many different reasons, and sometimes they simply lack the knowledge about how to go about making them, or, I think at least equally, and sometimes more the case, the confidence to give it a try. We need to face the fact that our service systems have fostered people's dependency, and that we can't expect people to do these things right the first few times they try. It's like giving a teenager the keys to the car without driver training and say, give it go. I mean, bad things can happen. Other times, people actually have trait barriers, those things that are unlikely to change, like neurological barriers or limitations, and state barriers that can change, like relapse, that affect people's ability at any given time to be able to make decisions. On a practical level, people need practice. We need to take into account the source of the trouble in the client's capacity to make decisions and avoid a very common assumption that I've seen in the 25 years I've been doing this, that by virtue of the fact that someone made a bad decision 10 years ago or 20 years ago, and sometimes an extraordinarily bad decision, they no longer in future could ever have the capacity to make decisions for themselves ever, ever again. And it's just not the truth. The truth of the matter is that people do bad things when they're young, and they tend to do less bad things when they're older, and that people learn and they grow. And we just have to get away from this acute mindset that people at their worst demonstrate however they will be henceforth. It's not true. I also want to say, though, on the other side, that we need to give people a chance to get well. And I don't think our system does that very well right now. In order to help people make good decisions, they need to have the supports they need, including inpatient support for longer periods of time if they want it. And our system, with the reduction of inpatient beds and the constant pressure to no sooner get people into inpatient units than to get them out, does not support that. Finally, I think we need to address the institutional, regulatory, and policy barriers. The principle here is that talk is cheap, and if we want shared decision-making, we need to do the hard work of clearing the path for it to happen. And it is going to be hard work, because there's lots of systems and policies that don't support it. Compliance-driven systems and language needs to be stamped out. We just need to stop using it. We need to stop saying, is this person medication compliant or are they treatment compliant? Because that means that we made the decision for it. Also, sometimes the clinicians need to establish medical necessity. Often, they need to establish medical necessity to get paid for their work, and doing the work that the client wants help on seems completely irreconcilable. You cannot do both at the same time. Licensing and other regulations needs to stop focusing on the dust on the windowsill, because that's a lot of what we get into, and start to focus on asking people, were you involved in the decision about what you got? Do you feel good about what you're getting? Are you moving on in your life? Also, someone or all of us needs, and this is my outrage, this is my particular outrage, needs to get to schools, needs to get to colleges and universities, because people who are going through those programs don't understand any of this. I don't know who those folks are that are professors nowadays, but they must be very old, and they never practice. And they don't, I'm sorry, I'm old too, so I can say it now. You know, they just don't get it. They don't understand what these jobs are about, they don't understand what the work is about, and people are being actively trained in the wrong thing, and then we have to untrain them. So I think that at a state level, it would make a lot of sense for EOHHS to get to at least the public universities and start to talk turkey. I think lastly, it's very difficult when you can't get paid enough to do the work. And we are about to have serious capacity issues in terms of basic access to medication services, etc., with the changes in the state. And another institutional barrier, as I see it, is the payment structure for a lot of our services, not the least of which is medication. And I think we are about to hit a tsunami on getting people the basics. I see medication for many people as a foundation. It does not get you a life. It doesn't do much else, but it is a heck of a good foundation for a lot of people. And if they don't have that foundation, shared decision making becomes more difficult. Thank you.